Hello everyone in Cardio Minds channel, and we are speaking today about another specific type of infective endocarditis, as we are going to speak about prosthetic valve endocarditis. In this video we are going to speak about three types of prosthetic valve endocarditis. First of all, surgical prosthetic valve endocarditis, in which a patient had open heart surgery for mitral valve or aortic valve replacement and then had developed infection on this prosthetic valve. Infective endocarditis following transcatheter aortic valve implantation, famously known as TAVI, or infective endocarditis following transcatheter pulmonary valve implantation. Let's start with surgical prosthetic valve endocarditis. Of course, it is the most severe form of infective endocarditis, occurring in about 1 to 6% of patients who had valve prosthesis, and it accounts for about 20 to 30% of all cases of infective endocarditis. It may be more common to have infection in a biprosthetic valve than mechanical valve prosthesis, apart from what many believe that mechanical prosthetic valve are more liable to infection than the biprosthesis, and also it is associated with higher in-hospital mortality and reduced long-term survival in comparison to native valve endocarditis, and of course a higher risk of perivalvular complications compared with native valve endocarditis, like perivalvular abscess and pseudoaneurysm. That's why we are usually afraid of prosthetic valve endocarditis, and that's why we are going to speak in the treatment that many doctors tend toward surgery. We have a distinction of two types of prosthetic valve endocarditis, early and late, based on the time since valve surgery, as the early usually occurs in the first year after valve replacement and late more than 1 year after valve surgery. However, the time to onset of infective endocarditis is prognostically less important than the connection of infective endocarditis to the perioperative periods or not, and the specific pathogen responsible for the infection. So not only the time from the surgery to the onset of infective endocarditis determine the pathology and prognosis, but also other factors. For example, prosthetic valve endocarditis with an onset in the perioperative period usually involves Staph aureus, Staph epidermidis, or nosocomial microorganisms like gram-negative pathogens, or in immunocompromised patients, fungal infection, whereas the late prosthetic valve endocarditis mimics the pattern of native valve endocarditis, mostly caused by streptococci or staphylococci. Staph aureus is more commonly observed in those with mechanical valves, whereas the biprosthetic valve are usually affected by the alpha hemolytic streptococci, enterococci, and coagulase negative staph. How are we going to diagnose prosthetic valve endocarditis? The clinical presentation is frequently atypical. We know that in the early postoperative period, fever is common, and usually the patient has rise in the inflammatory markers. So in absence of macroscopic or gross alteration of the prosthesis in the imaging, a diagnosis of infective endocarditis may be missed. However, persistent fever in a patient with a prosthetic valve, whether it is in the early phase or the late phase, should trigger the suspicion of prosthetic valve endocarditis. So for example, fever persistent for more than 4 days, don't wait for more time in order to diagnose or to exclude prosthetic valve endocarditis. Reminding ourselves, with the modified Duke's criteria for infective endocarditis, we have the major criteria: blood culture showing typical microorganism consistent with infective endocarditis from 2 separate culture, or microorganisms consistent with infective endocarditis from continuously positive blood cultures, or single positive culture, or elevated IgG titer for Coxiella perneti, and imaging positive for infective endocarditis like valvular, perivalvular, periprosthetic for immaterial anatomic or metabolic lesion, either by the echo, cardiac CT, PET scan, or SPECT CT. And the minor criteria: presence of predisposing condition, fever more than 38 degrees, presence of embolic complication, either symptomatic or even asymptomatic detected by imaging only, immunological phenomena, or microbiological evidence not fulfilling the major criteria. We consider infective endocarditis to be definite if it includes 2 major criteria, or 1 major and 3 minor, or 5 minor criteria, possible if it includes one major criterion with one or two minor criteria, or 3 to 4 minor criteria, and rejected, of course, if it doesn't meet any criteria for definite or possible endocarditis with or without another alternative diagnosis. So to diagnose prostatic valve endocarditis, you should ask for transesophageal echo. It is a class 1 recommendation, and you cannot depend on transthoracic alone because transesophageal has higher sensitivity in this case. And if the initial imaging was negative and you still have high clinical suspicion of infective endocarditis, you can repeat them after 5 to 7 days. And remember that the diagnostic value of transesophageal echo is lower in prostatic valve endocarditis than the native regarding the detection of vegetations, but it is more sensitive in detection of periprostatic complication. That's why we usually need additional imaging, not depending only on the echo. So we usually ask for PET-CT and cardiac CT in possible prostatic valve endocarditis to detect valvular lesions and confirm the diagnosis of infective endocarditis, and cardiac CT is also recommended to diagnose paravalvular or periprostatic complication if the echo is inconclusive. And remember that brain and whole body imaging using CT, PET-CT or MRI are recommended in symptomatic patients with suspected embolic complication to add more minor diagnostic criteria. All of these investigations have class 1 recommendation. SPECT-CT can be an alternative in case of absence of PET-CT in patients with high clinical suspicion of prostatic valve endocarditis and the echo was negative or inconclusive. So the first choice for PET scan, but if it is not available, go for SPECT-CT. And if the patient is asymptomatic regarding any embolic complications, still class 2B to ask for brain and whole body imaging in order to detect any peripheral lesions that add to the diagnostic minor criteria. So this diagram summarizes how to use the investigations for suspected prostatic valve endocarditis. You undergo baseline assessment and depend on the clinical presentation, ask for blood cultures, ask for transthoracic and transesophageal echo, then use the 2023 diagnostic criteria. If it shows definite infective endocarditis, you ask for suspected paravalvular complications if the transesophageal echo is inconclusive, so arrange for cardiac CT. If there are symptoms suggesting extracardiac complication, ask for brain and whole body imaging. If there are no symptoms to suggest extracardiac complication, still class 2B to ask for whole body imaging. If it was possible infective endocarditis, we can repeat the blood cultures if they were initially negative or doubtful, repeat the echo within 5 to 7 days, ask for cardiac CT or PET-CT to diagnose valvular lesions. And we can ask for SPECT-CT if the PET-CT is not available, or ask for brain or whole body imaging to add more minor criteria, because here we are still in a possibility of infective endocarditis, not a definite diagnosis. If it is rejected in this case, we are going to search for alternative diagnosis explaining the symptoms. Then how are we going to treat prostatic valve endocarditis? Still debatable whether to go immediately for surgery or to wait and keep on conservative antibiotic treatment. In general, surgery is considered the best option in case of prostatic valve endocarditis causing prostatic dysfunction or heart failure. However, early valve replacement in many clinical trials was not associated with lower mortality compared with conservative treatment in a large international cohort. However, also, surgery was still beneficial in the subgroup of patients with the strongest indications for surgery, for example, large vegetation, dehiscence, paravalvular abscess, or fistula formation. This means that we tailor the indication for surgery according to the clinical situation of the patient. Therefore, surgery is recommended for prostatic valve endocarditis in high-risk subgroups like complication with heart failure, severe prostatic dysfunction, abscess formation, persistent fever, or early prostatic valve endocarditis in the first year or the first 6 months after surgery. And patients with uncomplicated non-staphylococcal late prostatic valve endocarditis can be managed conservatively with antibiotics without the need of surgery, except in case of development of complications. But you need close follow-up because this patient still has a risk for late events and risk of relapse even after complete recovery and risk of valvular dysfunction. So whenever you discharge this patient, keep in close contact with the patient because this patient may come to you again with another bout of infective endocarditis. And put in your mind that the reoperation for those patients and the higher incidence of periprostatic tissue destruction increase the complexity of the redo surgery. That's why it is not a routine that any patient with prostatic valve endocarditis go for surgery, because it is not an easy surgery. The redo surgery has a higher risk than the first valve replacement surgery. So the recommendations is the guidelines for the prostatic valve endocarditis that surgery is recommended as a class 1 for early prostatic valve endocarditis within 6 months, because mostly it is a nosocomial infection needing new valve replacement with complete debridement of the infected valve. And regarding the antibiotic treatment, patients with early prostatic valve endocarditis in the first year after surgery, or nosocomial infection, or non-nosocomial healthcare associated endocarditis, we can start with vancomycin or daptomycin combined with gentamicin, and rifampicin is essential because it has a high success rate to eradicate infection in early prostatic valve endocarditis. These are the dosage for the adults and the dosage for the pediatrics, and it is still class 2B due to limited evidence for early prostatic valve endocarditis. Apart from this, patients with late prostatic valve endocarditis more than 12 months. Remember that here when he speaks about early and late regarding the antibiotic therapy, he used the 12 months distinction. But when he spoke about surgery, he meant by early the first 6 months. In those patients with late prostatic valve endocarditis, it is the same treatment as a community-acquired native valve endocarditis, using ampicillin in combination with ceftriaxone or flucloxacillin and gentamicin for maximum 2 weeks to avoid nephrotoxicity. This is class 2A recommendation for conservative treatment. These are the dosage for the adults and the dosage for the pediatrics. And remember that we keep on conservative treatment in this case, provided that the patient has no complication. If he started to develop any complications mentioned before, then we are going to speak about the indication for surgery. Then we are moving to the second type, which is infective endocarditis following TAVI. TAVI is increasing nowadays, as we know, so infective endocarditis is not uncommon. The risk of infection is higher in the first year following TAVI, especially in the initial 3 months, so mostly it is a nosocomial infection. But there is a modest decrease in the incidence of infective endocarditis post-TAVI nowadays due to multiple technical improvement in the procedure and reduction of peri-procedure complications, including infection, AV blocks, or any vascular complications nowadays. The most two common organisms to cause infection post-TAVI are the enterococci and Staph aureus, and also streptococci and coagulase negative staphylococci can cause infection in the bioprostatic valve. The diagnosis of infective endocarditis post-TAVI is difficult and challenging due to multiple factors. First of all, the stent frame of the transcatheter valves has higher amounts of metal surrounding the leaflets in comparison with the surgical prosthesis, so it is difficult for the echocardiographer to assess the leaflets of the bioprostatic valve to determine whether there are vegetations or not. Also, the characteristics of the TAVI patients, they are frequently elderly with multiple comorbidities. They may be poorly echogenic, poorly aligned parasternal long axis view, so it is difficult to assess the valve by echo. Also, the clinical presentation is frequently atypical. Patient may be afebrile. Fever is absent in 13 to 20% of patients post-TAVI. That's why we usually ask for transesophageal echo post-TAVI to diagnose infective endocarditis, but be cautious about certain considerations. First of all, there are no vegetation detected in 38 to 60%, so it may give you false negative results. Vegetations sometimes are located on the stent frame of the bioprostatic valve, not on the leaflets as we are commonly seeing, and sometimes the vegetations are located outside the transcatheter valve in about 1/3 of patients. That's why transesophageal echo is not enough, and sometimes you need PET CT or cardiac CT for the diagnostic workup of infective endocarditis in TAVI. So transesophageal and transthoracic echo may give you false negative results. What about the prognosis? Unfortunately, patients with TAVI are usually older, having more comorbidities than post-surgical prosthetic valve endocarditis. That's why their prognosis is not good. About 2/3 of patients show complications, at least one, like the most common acute kidney injury or heart failure. And the in-hospital mortality and 30-day mortality rates are very high in comparison to surgical prosthetic aortic valve endocarditis. Then, how are you going to treat infective endocarditis post-TAVI? Of course, antibiotic therapy is a cornerstone, similar to the same regimen of prosthetic valve endocarditis. And surgery is considered the best option in presence of complications like severe prostatic dysfunction or heart failure. But also it is infrequently performed compared to native valve or surgical prosthetic valve endocarditis. Why? Because this patient is usually high risk, advanced age, frailty, high surgical risk. That's why he was having TAVI from the start, not surgical aortic valve replacement. So this patient is not fit for surgery from the start. Sometimes the patient is low risk for surgery, but the problem is that to remove a TAVI by prosthetic valve with a large amount of stent frame that was adherent to the ascending aorta, it is a high risk surgery, not easy, and carrying a high risk of complications. That's why the decision to proceed with surgery in infective endocarditis post-TAVI should be individualized, balancing the surgical risk and the prognosis of medical treatment alone, because it is not an easy decision. And in case of local extension of the infection, surgery may be recommended in the absence of prohibitive surgical risk. Another option in patients with healed infective endocarditis, so he had a recovery of the infection, but he's still having prosthesis dysfunction, you can repeat a transcatheter therapy called valve-in-valve procedure that can be performed in selected patients, but at least 1 to 3 months after the healed episode of infective endocarditis and following a negative follow-up transesophageal echo. But as we see, there are no specific recommendations so far for the infective endocarditis post-TAVI regarding the antibiotic treatment or the surgery. The last disease is the infective endocarditis following transcatheter pulmonary valve implantation. Still uncommon disease to be seen because this procedure is not very common, usually performed for patients with congenital heart diseases like, for example, post-failure repair having pulmonary regurgitation, but its incidence is increasing nowadays. First of all, its incidence ranges from 1.6 to 4 per 100 patients per year, which seem to be higher than reported following surgical pulmonary valve intervention. And the most consistent factors associated with increased risk of infective endocarditis following this procedure is younger age, as most patients here are young, having congenital heart diseases or previous history of infective endocarditis, or higher residual gradient across the bioprosthetic valve. How are we going to diagnose this specific disease? Still challenging, the same as in infective endocarditis post-TAVI. So usually transthoracic and transesophageal echo are not enough because they may give you false negative results, and you need to arrange for PET CT or cardiac CT to confirm or exclude the diagnosis of infective endocarditis following this procedure. Staph aureus and oral group streptococci are still the most common microorganisms causing infective endocarditis following transcatheter pulmonary valve implantation. What about its prognosis? Unfortunately, moderate or severe prostatic valve stenosis occurs more frequently in post-transcatheter pulmonary valve implantation than aortic prostatic valve, and the rate of surgical valve replacement is high, ranging from 26 to 56%. However, good news is that the mortality rate here is much lower than TAVI patients. Why? because the patients here are usually younger with less comorbidities in comparison to the TAVI patients. So maybe the risk of complication in the pulmonary valve is higher than in the aortic valve, but the mortality rate is lower due to the quality of the patients here having transcatheter pulmonary valve implantation. So how are we going to treat this entity? Antibiotic therapy is still a cornerstone, similar to the antibiotic regimen of prosthetic valve endocarditis and the post-TAVI. Surgery or intervention, there is a good rule here for valve-in-valve intervention to treat severe prosthetic dysfunction after healed infective endocarditis. Or if you are in urgency, arrange for balloon dilatation in severe valve stenosis. This has reported success rate in infective endocarditis post-transcatheter pulmonary valve implantation. But beware that you should wait at least 1 to 3 months following antibiotic treatment to make sure that there is good healing of the infection before valve-in-valve procedure. If it is not possible in this case, we are going to arrange for surgical excision of the bioprosthetic pulmonary valve. So we have reached the end of our video today, as we have discussed 3 specific entities of prosthetic valve endocarditis. Our take-home message that we use the same diagnostic criteria for prosthetic valve endocarditis as in native valve endocarditis. But be cautious in selecting the appropriate investigation, because sometimes transthoracic and transesophageal echo have a high possibility to be false negative. That's why we usually ask for other investigations to confirm or exclude the diagnosis, like PET-CT, SPECT-CT, or cardiac CT, in order to detect any vegetations or evidence of infection on the mechanical or the bioprosthetic valves. Thank you very much for watching this video, and wait for the last video, as we are going to speak about cardiac implantable electronic device related infective endocarditis.